Hypertension Council of the CSI. He has approximately 65 publications in national as well as international peer-reviewed journals to his credit, with 3 national narrations, an author of 5 books, with his latest book being The Magic of Indian Medicine. He is also a prolific speaker, as we all know, a TEDx talk speaker, and a top writer in Quora blogs. Dear sir, over to you.
Thank you, Dr. Partha, for that introduction and introducing the topic of heart failure, how serious it is in India. And to talk about that, I think today we have a fantastic collection of speakers. We have Professor John McMurray, who is the go-to man for heart failure. I mean, he's the one who has been teaching us heart failure every year. Whatever new has come, you can see his CV. He is the professor at the Queen Elizabeth University Hospital at Glasgow, United Kingdom. He has been the PI of almost all the trials that you read, we read, and all of us learn, right? Start from CHARM to iPreserve, from emphasis heart failure, paradigm, HF to Paragon, from what DAPA, CKD, DAPA, HF to Deliver. You talk about it and he is there as a PI. So I think there is no better person who can talk to us about his topic of heart failure from bench to bedside. Understand that almost every drug goes from bench to bedside, right? But today we have drugs like SGLTs, which has gone the other way, right? We have learned that they do good to our heart failure patient, and then we went back looking at how they do it. So this complexity, Professor McMurray talked to us about it. Followed by that, we have, I think, a very important session, what we call as a face-to-face talk to each other. We have 2 extremely academic people with us. We are so fortunate to have you with us, Professor J.C. Mohan. Dr. Mohan is, to my mind, he's one of the topmost academicians in India, and we go to him whenever we need to learn something. He is kind of encyclopedia of trials. He can just tell you all the data of what our trial has. We have great respect for him. He is the chairman of the Jaipur Golden Heart Hospital at New Delhi. You can see his CV there, 370 publications. He's the executive committee member, the Cardiology Society of India. He's written 3 books, multiple chapters, and he has been given huge amount of awards. So welcome, Dr. J.C. Mohan.
Thank you.
This meeting. Thank you. We also have Dr. Brian Pinto from Mumbai. Dr. Brian Pinto is the Director of Cardiology and Cardiovascular Service at the Holy Family Hospital. Dr. Pinto is one of our very favorite colleagues. We always smiling, and he's always ready to contribute to his academics. You can see he has won many awards. A research interest in interventional cardiology, rotational atherectomy, and transradial interventions. He had been the proctor of many of the newer interventions, 25,000 intervention procedures, right? Not an easy step. He has been the Secretary General of India International Forum of Cardiology, conducted many meetings. He is one of our favorite colleagues. Welcome, Dr. Brian Pinto, to this meeting. Is Dr. Pinto online? Or maybe we'll wait for him as he joins up. So we start with the first talk of heart failure from bench to bedside by Professor John McMurray. Professor McMurray, please.
So thank you very much indeed for that very nice invitation. It's nice to speak to some friends from India again. And thank you everybody else for joining. Now I'm just attempting to share my screen. So hopefully you can see my screen.
Yes, it's visible.
You can see it, okay. Well, it's a very important day today because, oh, hold on, it looks like something's happened to Zoom. Just let me start again. Can you still see my screen?
Yes, sir,
Your
it's
slides
visible.
and we can hear you. You are fine, loud and clear.
Okay, it's just I'm getting some sort of error message for some.
I think there must be a network bandwidth.
Maybe you can log out and log in again.
Dr. John, you need to unmute yourself, sir. You got muted.
If you can unmute Dr. McMurray.
So we have shared the request.
Yeah.
Yes.
Right.
Okay, so can you see my screen and hear me? It's just there seemed to be some problem. I'm very
But
sorry.
we can see your
There was.
screen and we can
Okay.
hear
We can
you.
hear you, sir.
Okay, good. So I was saying today's a very special day for me because, of course, it's St. Patrick's Day. And as an Irishman, this is our national day. So that's why I've got my shamrock at the top of my slide. So I'm going to talk principally about angiotensin receptor neprilysin inhibitors. And in fact, the story is much more the case of bedside to bench rather than bench to bedside, I would say, unusually for drug therapy. And I'll explain that over the next few minutes. But of course, I'll also talk about other important developments in heart failure recently. So I'm going to start at the beginning of this century. And of course, as you all know, at the beginning of this century, these were our three foundational therapies, as we now call them, for patients with heart failure and reduced ejection fraction. Foundational therapies based on large randomized trials, the names of which you can see above each of the three treatments. And we've moved on a lot from this, and that's what I want to talk about in the next few minutes. And we've moved on, firstly, by moving away from simple neurohumoral blockade, so blocking the renin-angiotensin-aldosterone system with ACE inhibitors and mineralocorticoid receptor antagonists, to trying to modulate these systems. And by that, I mean also exploiting the good neurohumoral pathways that exist. So we understand, obviously, blocking, antagonizing the detrimental neurohumoral pathways, but there are beneficial neurohumoral pathways, and we spent a long time trying to understand how to enhance, augment, and exploit those pathways, the best known of which, of course, are the natriuretic peptides. And in fact, when I started my research in cardiology, I started by studying natriuretic peptides because I was fascinated as a young doctor in training by the discovery that the heart was actually not just a pump, but was an endocrine organ, and that it produced these two peptides, ANP and BNP. We subsequently discovered blood vessels produce CNP, kidneys produce another natriuretic peptide called urodilatin. And these two peptides, ANP and BNP, were secreted by the heart in an attempt to protect itself from volume and pressure overload. This was the heart's endogenous protective system. And we set about trying to find a way to enhance that system. Could we augment that? Could we use that as a treatment for our patients with heart failure? And eventually it was figured out how we could do this, and that was by using drugs that inhibit an enzyme called neprilysin, and neprilysin is responsible for the breakdown of natriuretic peptides. It's also, and this will become more important as I go through my presentation, responsible for the breakdown of many other vasoactive and metabolically active peptides. And probably, in truth, the beneficial effects of neprilysin inhibition are not just due to an effect on natriuretic peptides, but that's where we started. That is the way in which we thought inhibiting neprilysin, inhibiting the breakdown of these peptides, would be beneficial in patients with heart failure. Now, believe it or not, it took 25 years of studying different drugs to figure out how to do this safely and effectively. And in fact, Novartis developed this combination of valsartan, so a renin-angiotensin system blocker, an angiotensin receptor blocker, and a neprilysin inhibitor, sacubitril, and that was eventually the way in which we were able to show that inhibiting neprilysin was beneficial in patients with heart failure. And we did that in a very large randomized trial. In fact, I believe this remains the largest positive randomized trial to date in heart failure. And we didn't have much bench evidence. We really took this drug straight into the bedside, into the clinic, and did a trial in over 8,000 patients comparing sacubitril valsartan to what at the time was the gold standard, which was enalapril. So this is very simply what the Paradigm heart failure trial was about. It was about looking at the effect of adding a neprilysin inhibitor on top of what by that stage was standard background therapy, beta blocker, RAS blocker, and in over half of the patients, a mineralocorticoid receptor antagonist. This group, of course, was sacubitril valsartan, and in the control arm, this group was enalapril. That was required of us by the regulatory authorities because enalapril is the most evidence-based ACE inhibitor in patients with heart failure and reduced ejection fraction. So as I said, we randomized almost 8,400 patients to receive either enalapril plus a beta blocker plus an MRA in over half of the patients, as I mentioned, or sacubitril valsartan added to those background therapies. And you can see here the primary composite endpoint, time to first occurrence of cardiovascular death or heart failure hospitalization, was reduced significantly. In fact, this was one of the smallest p-values I think any of us have ever seen with any treatment in any clinical trial. There was a 20% highly statistically significant relative risk reduction. So proof that adding a neprilysin inhibitor on top of these other foundational therapies further improved prognosis. So actually very quickly after that, in fact, in the 2016 ESC guideline, a neprilysin inhibitor combined with a RAS blocker, in other words, sacubitril valsartan, quickly became a new foundational therapy with a class 1 recommendation for patients with heart failure and reduced ejection fraction. Now, I do want to stress that this is 2 treatments in 1 pill. This is 2 distinct pharmacological entities combined in 1 pill. It's very important to remember that this is not an alternative renin-angiotensin system blocker alone. This is a RAS blocker plus a neprilysin inhibitor. Now, since then, there's been an explosion in publications about sacubitril valsartan and the value of neprilysin inhibition in patients with heart failure. And I'm going to talk about some of these, but of course, I can't talk about all of them in the short time available. So I'm going to go through some of the selective publications that have come out since 2014. I think one of the most interesting was one that we published a year after the main results of Paradigm heart failure, looking at mode of death. We know that patients with heart failure die principally from cardiovascular causes, and sacubitril valsartan reduced the risk of cardiovascular death by 20%. But we also know that those cardiovascular causes are basically either sudden death, which we usually presume is due to an arrhythmia, or death due to worsening heart failure, worsening pump failure. And you can see here that both of those 2 major modes of death were each reduced significantly. And interestingly, you can see that in these patients with relatively mild symptoms, the major mode of death is sudden death. And I think it's very important to stress that, because often people think, I don't need to change my patient's treatment. I can wait to see if their symptoms get worse. And at that point, I can improve their therapy if needed. If you take that approach, then in fact, many of your patients are simply not going to come back to tell you that their heart failure is getting worse, because they will have died suddenly, and you can reduce the risk of sudden death by about 20% by changing from an ACE inhibitor or ARB to sacubitril valsartan, in other words, by adding a neprilysin inhibitor. And indeed, last year, we did a very careful retrospective analysis of this enormous database, and were able to show, as you might expect from that effect on the sudden death, that indeed there is a reduction in malignant ventricular arrhythmias, and neprilysin inhibition has an anti-arrhythmic effect. It reduces the risk of ventricular arrhythmias and sudden death. And of course, I don't want to forget about the other things that are important. So reducing mortality clearly is a goal of treatment, but also so is reducing hospital admission. It's usually a very expensive burden on the health service in many countries, and in some countries where patients have to pay for their own health care, it's also a big burden on patients. And of course, improving symptoms and quality of life. And I'm putting this slide up really because it serves two purposes. One is it shows that sacubitril valsartan reduces heart failure hospitalization just as it reduces the risk of cardiovascular death. So there's a 19% reduction in heart failure hospitalization, again, highly statistically significant, but it also serves the purpose of reminding me to say to you that in all of the subgroups that we looked at, really, there was a very clear benefit. And this one just happens to be subgroup analysis looking at different age groups, showing that even in very elderly patients, there is a clear benefit of adding a neprilysin inhibitor, in other words, switching to sacubitril valsartan on heart failure hospitalization and even on mortality. And then lastly, as I mentioned, of course, another key goal is actually improving how patients feel, or at the very least, trying to prevent deterioration, because we know that heart failure is a progressive syndrome. Often patients' symptoms and quality of life deteriorates. But I think that doctors don't realize how common that is. And I didn't realize how common that is. And it was really the data from Paradigm Heart Failure that taught me a very important lesson in this respect. And I'll just explain why I believe that. So what this slide shows you is change in a patient-reported outcome. This is the Kansas City Cardiomyopathy Questionnaire, KCCQ, clinical summary score. This figure shows you the change between baseline and 8 months. And what this tells me is that in a very short period of time, a large proportion of patients deteriorate. This is the proportion of patients reporting a 5 or greater point deterioration in their Kansas City score. A 5 or greater point change is regarded as a clinically meaningful change. And look at what happened between baseline and just 8 months after randomization. The green bar is the enalapril group. More than a third of these patients told us when they filled in that questionnaire that they had experienced in this very short period of time a clinically meaningful deterioration. Now, remember, these patients had predominantly NYHA class 2 symptoms at baseline. They were very well treated using conventional therapy, more than 90% on a beta blocker, all of them on full dose enalapril, more than half on a mineralocorticoid receptor antagonist, yet more than 1 in 3 had a clinically meaningful deterioration within just 8 months. So we need to act, and we need to act quickly for these patients. I'm sure you've heard people like me talk about clinical inertia, that tendency not to do anything. Here's a reason why we have to do things, because these patients are deteriorating in front of our very eyes, and we're probably not even realizing it. We only saw this when we looked at these questionnaires that the patients had completed. And of course, adding an neprilysin inhibitor, switching to sacubitril valsartan, reduces the likelihood of clinical deterioration. In fact, the number needed to treat to prevent one patient having a clinically meaningful deterioration was only 23. That's a very small number needed to treat. And we've drilled down into this questionnaire in more detail. As I said, there are 23 questions in the questionnaire. Of course, the patients were filling these questionnaires in blind to knowledge of which treatment they had been randomized to. And what I've shown you here is the placebo-corrected change, the enalapril corrected change with sacubitril valsartan. So these bars represent the difference between sacubitril valsartan and enalapril. And if there is an increase, so if there's a positive change, that represents an improvement with sacubitril valsartan compared to enalapril. And you can see across the range of activities that the patients answer questions about, there is a greater improvement with sacubitril valsartan compared to placebo, including in doing all the things that matter to patients a lot. So strong evidence that neprilysin inhibition improves symptoms, well-being, quality of life more than just blocking the renin-angiotensin system by itself. Now, again, there was a lot of questions after we did Paradigm about, could we start this treatment in hospital? People were worried about the fact that it lowers blood pressure more than enalapril and so on. So I want to show you another, I think, very important study. It was a lot smaller, but it was still, I think, very, very important. And that is the Pioneer HF trial published a few years later. Now, it was a relatively short trial. It lasted only 8 weeks. The reason it lasted only 8 weeks was because it was felt unethical to continue people on enalapril once they had stabilized after being admitted to hospital, because around this time they transitioned from being pioneer patients to becoming paradigm patients. And we'd clearly shown that sacubitril valsartan improves survival compared to enalapril. So it was thought to be unethical to continue enalapril for longer than this first 8 weeks of treatment. So these were patients hospitalized with worsening heart failure, patients with HFrEF, and patients were started as soon as they were stabilized. It could be as early as 24 hours after admission, were started on either sacubitril valsartan or enalapril. They were started on half the target dose, and then they were up titrated, as you can see here. Now, this was a very different patient population than in Paradigm heart failure. These patients were more often Black, African American, rather than white patients, which was the predominant population in Paradigm. Many of these patients had never been on a RAS blocker before. A lot of them were newly presenting cases with heart failure. So you can see here that over a third of patients had no previous diagnosis of heart failure. You can see their baseline systolic blood pressure. And of course, they had a much higher NT-proBNP than in Paradigm. Because this was a relatively small study and short term, the primary endpoint was reduction in NT-proBNP, reflecting reduction in left ventricular filling pressure and wall stress. And you can see that as early as 1 week after randomization, there was a significant reduction in NT-proBNP with sacubitril/valsartan compared to enalapril. And you can see over here to the right of the slide, tolerability. And tolerability we thought was pretty good in this trial. You can see that even symptomatic hypotension was actually in this much more vulnerable acute population, only a little bit more common in the sacubitril/valsartan group than in the enalapril group. But what was really interesting was that there was a pre-specified clinical composite outcome. I don't think anybody really expected in a few hundred patient study for only 8 weeks that there would be a significant difference. But in fact, in the 56 days of follow-up, you can see that compared to enalapril, sacubitril/valsartan actually reduced the risk of this composite outcome. The risk reduction was primarily due to a reduction in heart failure readmission. So even within a very short period of time, there was this significant benefit. And we think this is probably real because actually in paradigm heart failure, we also saw a significant benefit within just 30 days of patients being randomized to sacubitril/valsartan compared to enalapril. Here are the safety outcomes in paradigm for comparison. So again, a bit more hypotension, but obviously a lot less common in this ambulant outpatient population. We saw less renal dysfunction in the sacubitril/valsartan group. We saw less serious hyperkalemia, and we saw similar amounts of angioedema and, interestingly, less cough than with enalapril. So a pretty good safety profile. Now, just before I switch to talk about the treatment of patients with heart failure and an ejection fraction of 40%, or sorry, above 40%, I also want to briefly say, of course, there's another very, very important new therapy for patients with HFrEF, even more recently discovered than neprilysin inhibition. And of course, that is inhibition of this sodium glucose co-transporter, the second member of the family found in the proximal renal tubule. And SGLT2 inhibitors, of course, have also become a crucially important treatment for patients with heart failure and reduced ejection fraction. We now have 2 trials of these drugs, DAPA-HF and EMPEROR reduced, showing, as you can see here, for the same endpoint that I just showed you in paradigm, remarkably similar benefits, in fact, an identical hazard ratio of 0.75, a 25% relative risk reduction. And these treatments are complementary and additive. They work in different ways. If you give the patient both of these treatments, they get more benefit than with either treatment by itself. You can see here in the 2 SGLT2 inhibitor trials in patients who were getting an ARNI at baseline, if you add an SGLT2 inhibitor, you further reduce their risk. So since 2014, we now have another treatment that can further improve outcome for these very high risk patients. And that's why all of our new guidelines now have both of these treatments, sacubitril/valsartan and an SGLT2 inhibitor, as one of the foundational therapies for patients with heart failure and reduced ejection fraction. 4 pills, I would say 5 different treatments, all working through different mechanisms of action. These mechanisms are complementary, the benefits are additive, and this is how you maximize benefits, minimize the risk that these patients are at by using these 4 different treatments, and they can be used in the majority of patients. And of course, today we recommend trying to start these treatments as quickly as possible because they all act so fast, and that is the best way to reduce risk. So let's switch completely to talk about the other patients with heart failure, those individuals who have an ejection fraction above 40%. And again, we did a very large trial with sacubitril valsartan. In those patients, that trial was called Paragon Heart Failure. Here we compared sacubitril valsartan to valsartan. We didn't use enalapril because we didn't have to use enalapril. There is no RAS blocker proven to be beneficial in patients with this type of heart failure, so we could choose whichever comparator we liked, and we chose valsartan because that gave us a cleaner pharmacological comparison. Basically, we were comparing sacubitril to no sacubitril because both groups were getting background treatment with valsartan. So this is the primary composite outcome in Paragon Heart Failure. It was a total event, so all heart failure hospitalizations and cardiovascular deaths. And you can see here that although the hazard ratio is below 1, so this, or sorry, rate ratio, this equates to a relative risk reduction of 13%. This was not quite statistically significant. The upper 95% confidence interval was over 1. The p-value was 0.0587. It was not below 0.05. So technically, this trial overall was neutral. We just missed the primary endpoints. But we had a number of pre-specified subgroup analyses, as we usually do in all of our trials. And one of these stood out, and that was the subgroup analysis according to baseline left ventricular ejection fraction. And we pre-specified that we would look at that at the median value, which was 57%. So here you see patients with an ejection fraction at or below the median value. You can see that the hazard ratio here is favorable. These are patients with an ejection fraction above 57%, above the median value. You can see here that there is no convincing evidence of benefit. Now, normally I would be the first person to say, do not believe subgroups, to be suspicious about subgroups, to be worried that this might be a chance finding. But the reason I think this is probably true, and more importantly, the reason that the US Food and Drug Administration and other regulatory authorities believe that this is probably true, is because we've seen something very similar with other drugs acting on neurohumoral systems. Here is the CHARM program from a long time ago, where we had 3 trials in which patients were randomized to placebo or candesartan. Here you see the full spectrum of ejection fraction because we included patients with the full range of ejection fraction in the 3 trials in the CHARM program. This dark green line shows you a continuous hazard ratio. The shaded gray area is the 95% confidence interval around the hazard ratio. You can see that it is clearly below 1, in other words, indicating benefits of candesartan, up to an ejection fraction of just below 60%. The upper 95% confidence interval crosses 1 here. Very, very similar picture for mineralocorticoid receptor antagonists. So this is the RALS trial, the emphasis heart failure trial, and the patients in TOPCAT randomized in the Americas. So 3 trials. Again, you can see that the upper 95% confidence interval crosses unity around a value of 57%. And I've shown you the evidence for sacubitril valsartan. This is now Paradigm and Paragon combined benefits up to an ejection fraction of around 57%. So very consistent findings. And this persuaded the regulators that this is probably not a chance finding. And that is why the new guidelines, as you know, recommend, these are the American guidelines, recommend using neurohumerally acting drugs in patients with an ejection fraction at least up to 50%. In the ESC guidelines, we recommend all of these drugs in patients with an ejection fraction in what we call the mildly reduced range. We believe that if you have an ejection fraction up to 50%, you probably have heart failure with depressed left ventricular systolic function. You probably have neurohumeral activation, and you probably benefit from drugs that work through neurohumeral systems. So watch out for later this year. In fact, it may even be at the Heart Failure Association meeting in May of this year, the results of a new sacubitril valsartan trial. This is like the Pioneer trial. This is a study in HFpEF patients who have experienced decompensated heart failure. And we'll see whether this shows the same as Pioneer did in patients with heart failure and reduced ejection fraction. Now, again, I want to stress that there is even more positive news for this neglected group of patients, patients who've got an ejection fraction above 40%. And of course, that's once again with SGLT2 inhibitors, where, as you can see here, we have 2 new trials. And in both of these trials, there was a significant benefit from SGLT2 inhibitor therapy for this composite outcome, although mainly driven by reduction in heart failure hospitalization. But the thing that is different with SGLT2 inhibitors is that they seem to be a benefit across the full range of ejection fraction. So even in people with an ejection fraction above 55 or 60%, these drugs are beneficial. So let's again switch gears to maybe show you some new data, to maybe go a bit more back to the bench and show you some data about neprilysin inhibition that you may not know about and may not have seen. So the first thing I want to show you is a finding that I still find quite remarkable. And I find this remarkable for a number of reasons that I'll explain. So this shows you the effect of sacubitril valsartan compared to enalapril in the Paradigm trial on high sensitivity troponin T. And what you can see is that compared to enalapril, sacubitril valsartan reduces troponin T. It reduces evidence of cardiomyocyte necrosis. But what I found extraordinary was that in Paradigm, we were able to measure troponin in almost all of the patients. And even more amazing was that at baseline, you can see that more than half, in fact, close to 60% of patients had a high sensitivity troponin T above the 99th percentile. In other words, more than half of the patients had a troponin T level that would have led to a diagnosis of myocardial infarction if they had been admitted to your hospital with chest pain. So our patients who are walking around in the street with supposedly mild symptoms, getting really good treatment, are leaking troponin into their blood. They are undergoing continuous cardiomyocyte necrosis. And it is really amazing to me that this is happening. And we just don't know why that is. But it is no great surprise when you see data like this that you realize that these patients have this syndrome characterized by that progressive worsening over time and those very high risks of hospital admission and death that we know all about. And again, you can see here that compared to enalapril, sacubitril, valsartan reduced the proportion of patients who had these levels of troponin consistent with myocardial infarction. So I still find these data really, really amazing. Another finding I think maybe is not well known is that sacubitril valsartan protects the kidneys in patients with heart failure. So here is the enalapril group in paradigm heart failure. This shows you change in eGFR from baseline. And of course, there is this almost linear decline in eGFR over time. And if you add an eprolizin inhibitor, you slow that rate of decline, and you slow it significantly. Now, we know that SGLT2 inhibitors do this, and everybody's been very excited by the fact that SGLT2 inhibitors have this benefit. But in fact, sacubitril valsartan has exactly the same benefit. And you can see that very clearly in this figure. In fact, we've published a paper showing that this is even more the case in patients who have type 2 diabetes as well as heart failure. They get a particularly large reduction in that rate of decline in eGFR over time. And very recently, now that we have two large heart failure trials, we put both Paradigm and Paragon heart failure together, not to look at eGFR slopes, but to look at the type of composite renal endpoint that is used in chronic kidney disease trials. This is the type of endpoint used in the SGLT2 inhibitor chronic kidney disease trials. And what do you see? You see a 44% relative risk reduction in this composite kidney endpoint. So neprilysin inhibition is also protective of the kidneys. We believe that in fact it is works in a different way than SGLT2 inhibition, and that again, using both an neprilysin inhibitor, sacubitril valsartan, and an SGLT2 inhibitor maximizes renal protection in these patients. And again, you can see that if you look at BUN creatinine ratio. So we know that, for example, with ACE inhibitors, BUN increases. This shows you BUN creatinine ratio, but in fact, BUN by itself shows a very similar picture. We're not sure why this is. We think it's probably because of an effect on pre-renal failure, maybe an effect of antidiuretic hormone or arginine vasopressin, but certainly compared to placebo, RAS blockade increases blood urea nitrogen, and that is again a predictor of worse outcomes. But interestingly, if you look at sacubitril valsartan, in other words, the addition of an neprilysin inhibitor, you do not see that rise in BUN that you see with a RAS blocker by itself. So again, evidence that neprilysin inhibition is doing something good to the kidneys to stop the increase in BUN or urea that we expect to see with a RAS blocker. Now, I want to come back to some of the other peptides that neprilysin is responsible for degrading, for breaking down. And I mentioned that it is an enzyme responsible for the breakdown of other vasoactive and metabolically active peptides. And one of those is GLP-1, glucagon-like peptide 1. This is the peptide that we inject analogues of it in patients with type 2 diabetes. This is the peptide that's also broken down by dipeptyl peptidase 4, DPP4. So we give DPP4 inhibitors to patients with type 2 diabetes to increase GLP-1 and in that way reduce blood glucose. But actually inhibiting neprilysin, sacubitril valsartan, also increases GLP-1. This is some work from a French group, but we have replicated this in Glasgow. We found exactly the same thing, that sacubitril valsartan increases GLP-1 levels. And we think that this is likely to be one of the explanations for an observation we made in Paradigm, which was that compared to enalapril, shown in red, sacubitril valsartan, shown in blue, reduces hemoglobin A1C levels. And I think much, much more importantly, reduces the need for new insulin treatment in patients with heart failure. So these are patients with diabetes in Paradigm heart failure. So heart failure patients with diabetes, mainly type 2 diabetes, obviously. And you can see here during blinded follow-up, the proportion of patients started a new insulin therapy. And that proportion was reduced by 29% with sacubitril valsartan compared to enalapril. And we know that starting insulin is an extremely bad prognostic sign in patients with heart failure and type 2 diabetes. If you're on insulin, you're going to do much worse. And here you see this really striking reduction in the need for new insulin therapy. And in case you thought that might be because the comparator was enalapril, here is what we found in Paragon, a very, very similar picture. This is definitely due to the effect of neprilysin inhibition. And we keep discovering more things about neprilysin inhibition that are clinically relevant. Another substrate for neprilysin is substance P. Substance P plays a role in hematopoiesis. Substance P plays a role in creating erythrocytes. And interestingly, what we've also found in Paradigm heart failure, and this is a paper in Press in JACC heart failure, what we also found in Paradigm heart failure is that hemoglobin levels decline less in the sacubitril valsartan arm, shown in red, compared to the enalapril arm, shown in blue. But more importantly, if you look at the proportion of patients developing new anemia during follow-up in Paradigm at 12 months, at 24 months, you can see that compared to enalapril, patients getting sacubitril valsartan at 1 year were 30% less likely to develop new anemia. At 2 years, were 20% less likely to develop new anemia. And you can see here that we saw exactly the same thing in Paragon heart failure. This shows you decrease in hemoglobin over time. The sacubitril valsartan group is shown in red. The valsartan group shown in blue. Hemoglobin decreased less with sacubitril valsartan compared to valsartan. So this is not about the comparator. This is about the benefit of adding neprilysin inhibition. And we found very similar things for many other metabolic effects of these drugs. Here is uric acid. Uric acid is a very, very powerful predictor of outcome in patients with heart failure, even when you account for other prognostic variables. Patients with high uric acid levels have a much worse outcome. And interestingly, compared to enalapril, sacubitril/valsartan reduces uric acid levels. That was in paradigm heart failure. We saw exactly the same thing in Paragon. This is valsartan in blue, sacubitril/valsartan in red, significant reduction in uric acid levels with sacubitril/valsartan compared to valsartan. So somehow neprilysin inhibition reduces uric acid levels. And in fact, we also saw a highly significant and large reduction in the need to introduce new uric acid lowering treatment. You can see here, if you look at any uric acid lowering therapy, it's about a 30% relative risk reduction in the need for patients to be started a new uric acid lowering therapy. Now, remember, when the decision was taken to start treatment for elevated uric acid, or more likely because of an attack of gout, neither the doctor nor the patient knew what therapy the patient was taking. So these were decisions to start uric acid lowering therapy blind to knowledge of which randomized treatment patients were getting. So again, more evidence of really a broad range of different types of benefits. If you're interested, we tried to summarize what was known, at least until a couple of years ago, in this special edition of JACC Heart Failure. This is a whole edition of the journal devoted to sacubitril/valsartan, and it includes a very extensive review of everything that we learned in the first 5 years after paradigm heart failure. So you'd be pleased to know that this is my last slide. It's about sacubitril/valsartan, just to emphasize that we're talking about two different drugs working in very distinct ways, but of course with additive benefits. The novel part of this is sacubitril, which is an neprilysin inhibitor. I've tried to give you some sense of the very broad benefits of neprilysin inhibition, broad benefits on all the things that we hope an effective heart failure therapy will do, but also very broad renal, metabolic, hematological, and other benefits really that might not have been expected. And I still think this is a well-tolerated treatment. I've shown you that it causes less renal dysfunction, less hyperkalemia, although it does cause more hypotension, and it can rarely cause angioedema, but in fact, this is not more common than with an ACE inhibitor. So with that, I'd like to stop and thank you very much indeed for listening.
Thank you, Dr. McMurray, for that excellent lecture, on one of the best I've heard on RNA in recent times. You have welcome, Dr. Brian Pinto.
Thank you so much,
And I
Tiny.
can see Dr. Jesse Moon is already connected. I think it was a fascinating lecture, taking us through how heart is not just a pump, but an endocrine organ. You showed about ANPs, BNPs, and how they modulate a heart's own system, modulating the peripheral vascular vasodilatation. You took us through how RNA gives us benefit in HFrEF and a kind of journey through HFpEF, showing us the data on SGLT inhibitors too. You showed us how RNA also slows down renal deterioration in heart failure. You very nicely showed us something that I didn't know myself, the mechanism of how RNA reduces blood sugar through GLP-1. You showed us beautifully how RNA might be acting through substance P and giving us a better hemoglobin level. You showed us nicely as to how it modulates uric acid, which is a marker for worse outcome. So I think it has been a fascinating journey of RNA. You showed us that it is truly not just a neprilysin inhibitor coupled onto a RAS inhibitor, but it's a neurohormonal modulator. Now, I think we have the Indian experts too. But before I open up, I think if you ask me, one major concern in India that I have is this. The point is, we know that when we are talking about a patient of heart failure getting discharged, he goes home. From Dr. Javed Butler's data, we know that about 50% of them are going to have an event, death, sudden cardiac death, or heart failure hospitalization in the first 35 or 40 days post-discharge. So that first 1 month is crucial, right? And today we have drugs that are extremely effective and act very fast, as Dr. McNamara showed us. ARNI acts so fast. SGLT is very fast, right? So we have good drugs that act quickly. We have a patient who is going home who is likely to get an event in the first 1 month. And not just that, we have enough data, like you showed in Pioneer, that they are safe and effective if we start in hospital. So I think the challenge in front of us in India would be that we should be able to start these drugs before a patient is discharged. And that is the best time when we can do that. I mean, what would be your comment, Dr. J.C. Mohan, Dr. Brian Pinto, and Professor McMurray, of course. Dr. J.C. Mohan, would you tell us your take on that?
So the issue you have raised is initiating therapy with ARNI in acute decompensated heart failure patient as soon as the patient stabilizes. And I think based upon Pioneer HF data, although a small study, there isn't any doubt in my mind that if you are going to look at the dividends of ARNI, those are going to be much, much greater in this phenotype or subset of population. And hence, there is an urgent need to convince everybody who is involved in care of heart failure patients that at discharge, at least the patient should get ARNI definitely in treatment. There might be some caveats with very low blood pressure. And I do understand that John and Milton Packer did write an algorithm somewhere in December 2020, talking about SGLT2 inhibitor and beta blocker to initiate. But my gut feeling is that a good number, almost 70–80% of these people, the blood pressure allows us to use ARNI, and I feel that would be a good start. We ourselves actually looked at our data of 2017 and 18 acute decompensated heart failure patients discharged, and we found our use of ARNI at that time was 21%. We reanalyzed our data of last 2 years, we have almost reached 50%, which is a reasonable figure. It is not perfect, but we are making progress.
I think one small challenge here is that, see, for most physicians, they consider, well, I have given a RAS inhibitor, right, an ACE inhibitor and an ARB, and they don't mentally realize how different is an RAS inhibitor, like an ACE inhibitor and ARB, to ARNI in the background of heart failure, right? Because I remember Professor McMurray's data, which he had published in JACC, that showed that if you just replace ARNI from an enalapril, you have for all-cause mortality, you have an NNT of 21. And you give the patient a freedom of primary endpoint of about 1.6 years if he's 65 years old. I mean, fascinating. Dr. Brian Pinto, what is your take on, because you practice in Mumbai and you have so many patients of heart failure, what about your take on pre-discharge ARNI, and of course, all the Fantastic Four as we talk about?
I think, Tiny, that's a very good question. And I think the rapid sequencing, as John and others were talking about, has been really important to us. And we have now something like a checklist, which we have made in our hospitals and our clinics, like a pilot's checklist. So when you go through that, we checklist which drug has been given and which has not been started, so that we know for what reason that drug was not started. So on the first visit back, we can address that problem and then bring in that particular one of the four or whichever we want to bring in as early as possible. The second point I want to make is that blood pressure is not as big a challenge as we make it out to be. Many of these patients actually need good perfusion, and we confuse blood pressure with good perfusion. For example, if a patient's limbs are warm and he's passing an adequate amount of urine, then I don't worry so much about the blood pressure, because the blood pressure can still hang around about 90, or even 85 by 60, and you'll see that your patient is actually doing quite well. And a few days later, he will do better. You can also overcome this challenge by changing certain drugs. For example, you can change your carvedilol to bisoprolol. That helps you to get blood pressure on board. And you can stop using some of the drugs which are not required for heart failure, which you often see. For example, you'll see on a prescription amlodipine, which is not a drug required for heart failure at all. And I think these two, you must review them, like isosorbide dinitrate by itself, and you must review them. And occasionally, you may have to admit your patient to get ARNI on board. The important thing to state out over there is that when you do that, you are actually giving a 40% at the lower end of blood pressure. Enalapril does not act as well. And what we say is a 20% reduction in the difference between the two goes to almost 40% in that group of patients in paradigm, which you will see. And so I feel that I'm a big proponent of using ARNI, and I've seen patients respond immediately in terms of their quality of life. And even we have seen so many patients doing better, sudden cardiac death getting lesser, cardiac failure getting lesser. And, combination, as John McMurray pointed out, along with SGLT2 and the Fab4, is really important to get on board. And I think I agree with JC when he said that a good number of patients can actually be initiated with ARNI and, beta blocker and SGLT2 inhibitor sometimes, and you are already fit to go with your MRAs coming on. So I'm very pleased with the new drugs that are available to us, and I clearly feel that figure of mortality of 50% in 5 years has been changed. Article written by McMurray itself said that if you give these drugs, you extend life by 6.2 years. Thanks for giving me this opportunity, Tiny.
Dr. McMurray, your comments on that short comment on pre-discharge initiation.
I agree with everything that's been said 100%. I mean, I think we do manage to get most of our patients on these treatments before discharge, but I think probably hospital admission is longer in the UK than India. Our average length of stay is 10 days, something like that. So we've got the time to do it. I think you probably don't keep people in hospital as long as we do. And although Milton and I wrote about this idea, and we even wrote a paper analyzing trials suggesting the benefits of doing all of this quickly, there's actually, as you know, a recent prospective randomized trial called STRONG-HF that actually shows that this very intensive approach, and it is intensive, that's the problem, it requires work and effort, but this very intensive approach pays off. There is a big dividend. As you said, the vulnerable periods is where you have the opportunity to make a huge difference if you can get all of these drugs started. So it's hard work. We talked about inertia. That's the main problem. I'd say inertia is a bigger problem, to be honest, than tolerability of these drugs. By and large, they're relatively well tolerated.
Right. So I think for the large number of physicians who are also listening to it, be careful before you start. Like Dr. Yesimon said, the patient needs to be stabilized before you start. By stabilization, we mean that he has to be off IV inotropes for the first 24 hours, the last 24 hours. He has to be off vasodilators, IV vasodilators for the last 6 hours. His diuretic dose should not have been escalated in the last 6 hours. And of course, his systolic blood pressure, and like Dr. Brian Pinto said, perfusion should be good. The systolic blood pressure preferably more than 100. That's a time when you are going to initiate these kind of altering drugs. Now, Dr. McMurray, there's something interesting since you said about hospital admission in India. We were looking into that data. See, if you actually want to probably start all these 4, you might need to extend the hospital stay of your patient, right? Right, for a few days. So the point is here. See, we were looking into the cost. An average cost of keeping a patient in IP as an admitted patient 1 extra day in US roughly comes to about $4,500. In Switzerland, it was about $4,200. In Australia, it was $765. While in India, keeping a patient extra one more day in hospital, that is a high-fi hospital, government on average, the data was from West Bengal to North India to East and West everywhere. It was average $150 a day. That's it. So I think it's much more easier for us to ask the patient to stay in a general ward or a twin sharing room for 1 or 2 extra days. That does not cost much compared to the therapy we're instituting. And
I suppose it depends on your healthcare system. I mean, if you've got the facilities and the staff to see people frequently as an outpatient, patients maybe don't need to be in so long, but most of us, that's more difficult. It's just easier to do it when the patient's under observation on the ward. You can check their blood pressure, you can check their blood chemistry. It's just easier to do it.
Good. Now, I think that we are late, but then that brings us to a very important question in India. See, in India, everything, Dr. McMurray, runs on what we call as minuscule dosage. Every patient comes says that, sir, please don't give me much dose. My system doesn't tolerate. Please give me small dose. You give a metformin, you say, oh my God, 1,000 milligrams. Right. So, and the physician, we are always kind of, you can say, guilty of writing as smallest possible dose. Now, right, we know that all heart failure drugs, including ARNI, we should reach the top of the level dose as prescribed by the trials. But this low dose business is everywhere in the world, right? For example, that Moebi data that came in JACC, very fascinating, where they showed that if you look into the 3 different dosage range of ARNI, 113 milligrams, 240, and 380 milligrams. In all these 3 cohorts, the degree of reduction of left atrial volume index, left ventricular systolic volume index, ejection fraction rise, and NT-proBNP drop, everything was almost similar.
But it wasn't a randomized trial. That's the problem. It was an observational study.
So no, the point is we are not saying that don't give top of the line dose, but many of our patients, for our patients, probably not even 5% patients get a 200 BID dosage, right? And there was a data recently in Nature that came from Korea, where they were talking about ultra low dose of sacubital valsartan, where they're given a 25 BID and still showed some kind of benefit. So I think the point I'm trying to say is that I would also invite Professor Mohan and Dr. Brian Pinto's opinion. Whatever little dose you can give, your patient tolerates at discharge, please give it rather than not giving it at all. Arni. Dr. Mohan?
So let me just make a few comments. First, ever since the drug became generic, few of the Indian companies have brought 25 milligram dose. That is number 1 point, which wasn't available till Novartis was marketing it. Number 2 point is that I never saw that dose of 25 milligram initiating dose can be the dose, but the expert consensus group from China in August 2022 came up with this recommendation that those patients who are having severe renal dysfunction or who are on maintenance hemodialysis, you can start 25 milligram once a day also, because the blood levels or serum levels can rise as much as 2.5 times in patients who have severe kidney disease, and the half-life gets prolonged to 38 hours. I did not know this data. The Chinese actually probably know us better, know more than us, and they said you could give 25 milligram once a day in patients with severe kidney disease. Having made those observations, I definitely feel that 70% of the patients, confidently you can start 50 milligram twice a day, nothing happens to them. And this 70% is probably a conservative estimate.
Yeah, Dr. Brian Pinto, any opinion on those?
Yeah, so I think it's now that the price has come down, you may need to start some patients on the low dose, but there are a good number of patients, you must remember, that you could even start them on 100 milligram BID. For instance, there are patients whose blood pressure is on the higher side, whose renal function is quite good. There are patients who've already been on an ACE or an ARB on a significant dose. So you're not really starting them. They're not naive. They have already got, some kind of RAS blocker on board. So these patients can be started on a higher dose because everybody talks about 25 and 50 starting. It's true. You need to start slow. You need to go slow. But I have started some of the patients who are on RAS inhibitors already on a dose of 100 milligram BID. And I certainly push, especially now that the pricing is quite good. I try my best to get them up to 200 milligram twice a day. Having said that, all my patients are not on 200 milligram twice a day, maybe only 15 or 20%, because on the earlier patients were, price sensitive, as well as they wouldn't come back, and all those kind of small things happen. But I think it's getting better and better, and we are slowly creeping up to using at least 100 milligram BID, or some more, very frequently, even 200 milligram BID. But that's not the most of patients as far as 200 BID dose is concerned.
So I have a provocative question to Dr. John McMurray. Those 3-4% patients whose blood pressure still is above 140, despite 200 milligram twice a day of Entresto, or can we give more dose than 400 milligram a day?
I've never tried to do that, and I don't think I would. I explain why I say that. With the equivalent of 200 milligrams twice a day, you get 100% inhibition of neprilysin, so you're not going to get any further benefits. I would just go back to the other end. So I agree that some is better than none. I think you should always try and achieve the target dose as possible, but don't forget, in the Pioneer study, okay, so it was only just under 900 patients, but there was clearly benefit there. Only about half of the patients got to the top dose. So in reality, not everybody's going to get to the top dose. And even in that population where only half of the people did get to the top dose, there was clear reduction in natriuretic peptides, actually clear reduction in that composite outcome. So, I mean, we do have evidence that below target doses have benefits. I'm not sure, though, whether the dose that you mentioned, 25 milligrams twice a day, has much neprilysin inhibiting activity. I think that's the issue. I think you probably need, I would say, getting up to 100 milligrams. I'm struggling because ours is 49.51, so we have we dose it according to how much is in each pill. But I think you need the equivalent of about 100 milligrams twice a day to be sure that you've got substantial neprilysin inhibition. That's the issue. So if you give very low doses, basically you're just giving another RAS blocker, and that's not what we want to do. We want neprilysin inhibition on top of that. And to get neprilysin inhibition, to be sure you've got neprilysin inhibition that is substantial, I think you need to be more in the range of 100 twice a day, if possible.
The one more question I want to ask you, is there a differential response? I know in Paradigm HF you did not say, between ischemic heart failure and non-ischemic heart failure, the way we are perceiving?
Not at all, at least not in Paradigm. We've published that paper, at least in terms of clinical outcomes. Now, I don't know about cardiac remodeling. That could be different, because a lot of studies have suggested for all the drugs we use, you tend to get a bit more favorable remodeling in non-ischemic patients. It's not really hard data, but that's the impression, I would say, would be the best way to put it, you get. So that could also be true for sacubitril valsartan. I'm not sure, because there really aren't many good cardiac remodeling randomized trials. But in terms of clinical outcomes, and frankly, that is the most important thing, people with ischemic etiology get as large a benefit as people with a non-ischemic etiology.
I think it's 9:15, but we have a couple of questions coming up in the chat box. One of them is Dr. Rawat is asking, escalating MRA with ARNI becomes a challenge because of hyperkalemia. Any clinical pearls while escalating therapy?
So I don't find that hyperkalemia is a big problem with MRAs. I know we always talk about it and there's great fear about it, but actually it's really quite uncommon, and the data, I believe, show that. Now, how can you avoid it? Well, if you've pre-treated your patients with an ARNI and you pre-treated them with an SGLT2 inhibitor, you will minimize the risk of developing hyperkalemia if you add an MRA. And then, of course, you've got to think about all the other things that can cause hyperkalemia. I mean, believe it or not, people get left on potassium supplements. Doctors forget. It's a bit like Brian said earlier about amlodipine and nitrates. People also forget potassium supplements, or even potassium-sparing diuretics like tramtrine or amiloride. And then, of course, there are potassium-containing foods. I don't know what it would be in India, but for us in the UK, the main culprit is bananas. And also, actually, interesting things like a lot of people in the UK who've got heart failure use salt substitutes. So they've been told not to take salt. They like salt for tasting their food. They add a salt substitute, and of course, those are very rich in potassium. So it's really trying to eliminate sources of potassium from the diet, making sure there's no other prescribed cause of potassium, and then trying to use the other drugs that help avoid hyperkalemia. And of course, judicious use of diuretics also avoid hyperkalemia. I mean, one of the tricks the nephrologists have learned is that loop diuretics help them avoid hyperkalemia a lot in their patients with chronic kidney disease, because of course diuretics are potassium wasting drugs. So those are all the things that I would think about.
And of course, addition of SGLT inhibitors actually make your chance of hyperkalemia lesser.
Less.
More chance of MRA being tolerated.
Absolutely. So pre-treat your patient, I would say, with an SGLT2 inhibitor if you're worried about hyperkalemia.
I mean, JC1, we see some funny questions coming up here, talking about, since Dr. McMurray said that ARNI can produce lowering of A1C, GLP-1-like effect, and SGLT inhibitors also tend to lower blood sugar. Will such combination therapy produce hypoglycemia in my non-diabetic patient?
Well, that's a very interesting question. So quite remarkably, so SGLT2 inhibitors, we've not seen it. And I don't think we would ever see it except in patients on insulin, because glucose levels are sort of self-regulating. But believe it or not, in the Paragon heart failure trial, we did see significantly more hypoglycemia in the sacubitril valsartan group than in the valsartan group. Now, small percentages, but nominally, statistically significantly more common. So yes, it is a theoretical possibility.
I think one last question Dr. Hira has asked, that how to titrate dosage of ARNI in an old, frail heart failure patient of HFrEF.
So I took out, my lecture was far too long, and I took out a really interesting analysis that we've published in Annals of Internal Medicine recently, looking at the effects of sacubitril valsartan according to frailty. And believe it or not, there was a greater benefit in more frail patients than in less frail patients. So frailty is absolutely not a reason to avoid sacubitril valsartan. You have to take all the usual precautions. You have to watch for symptomatic hypotension. You have to watch for worsening kidney function, of course. You have to watch for hyperkalemia, but very uncommon. You have to do all of those things. But actually, these patients remarkably had a bigger benefit. And not only that, but were no more likely to discontinue sacubitril valsartan than valsartan. Now, the interesting thing is that, of course, discontinuation of all drugs, becomes more common in older and frailer patients. We see that in the placebo group of all of our trials, but there is no difference here between valsartan and sacubitril valsartan. So bigger benefit, no more intolerance, quite surprising.
Professor Mohan, any last comments before we end?
No, I think this was
Dr. Brian Pinto, you just
I always enjoy John's talks, because he brings out such uncommon things. For example, he brought out the stuff about BUN creatinine. He brought out the stuff regarding uric acid. Then he brought out also regarding GLP-1, some of the things that we didn't know. And I think that's what makes him interesting each time he comes on board. And I must say that, this was one of the most wonderful lectures on heart failure. And must thank him and thank all of you for having me on.
Yeah, and also the interest about troponin part. Actually, that was really interesting. That 60% of the people have high troponin levels in heart failure. That was absolutely very, very interesting data.
It still amazes me to this day.
Yeah, like you said, apparently fine people and they are secreting troponin. So one last final comment before we end. So do you guys all think that ejection fraction is going away? Because Professor McMurray showed that MRA, candesartan, ARNI, SGLTs, you don't need to look into ejection fraction anymore. So just NT-proBNP, symptoms, treat and go home.
I think there is a greater need. Yeah, there's a greater need to phenotype heart failure better. We certainly would know which patient would respond regardless of ejection fraction with ARNI. It could be that these patients should be volume loaded rather than having a pressure overload on the left ventricle. In case, even if the ejection fraction is 60%, but the patient's volumes are high and there is not concentric hypertrophy, maybe they'll respond to ARNI. My gut feeling is we still have to phenotype heart failure regardless of ejection fraction with regard to response to therapeutic agents better.
So, Dr. McMurray, one last comment before we go home.
That's for me?
For the Indian viewers, Dr. McMurray.
Oh, sorry. I think we have to measure ejection fraction. Absolutely must do it, because don't forget we have devices as well, and they have a very specific indication in people with a persistently low ejection fraction. Now, hopefully, we've reduced the number of those people, because these treatments are all great at improving ejection fraction over time. So I believe today we're not using as many devices as we used to, but there's still an important role for devices in some people, and we have to measure ejection fraction. And we must also not forget, occasionally you'll be surprised somebody's got cardiac amyloidosis. Of course, people have valve disease. So you want to know everything you possibly can know about your patient. So that means you must do cardiac imaging.
Yeah. So I think my last comment from my side is that reminds me, I was reading an article in JAMA about analysis from Paradigm again that says that if you look at patients who were in NYHA1, 76% of them had an elevated NT-proBNP. And those patients had a 3.4 times higher event rate. So to the listeners, one thing is that there is no mild heart failure. Your patient of heart failure might be in NYHA1, sitting quietly telling you, doctor, I'm feeling well. That does not mean that he is low risk, right? His NT-proBNP might be extremely high. He might be at a 4 times higher risk of an event in the next few days. He might have a sudden cardiac death. And as Professor McMurray showed, that these drugs also not just prevent a progression of heart failure, but prevent sudden cardiac death. So I think with that, we give the podium back to our organizers. And thank you for giving all of us a chance to talk and interact.
It was truly an academic feast to every hilt of the word, DSS. I take this opportunity to thank each and every one of you, Professor McMurray, Dr. Tiny Nair sir, Professor J.C. Mohan sir, and Dr. Brian Pinto. we are very sure that the audience which has attended the session has actually got wiser and actually has take-home messages which can empower them in their clinical practice. Just to add on, we've had more than 1,100 registrations all over India with a request for a version 2.0 of the same meeting. Also, I would like to thank each and every one of you, our esteemed audience, who have taken your very special time to log on at this time to upgrade your knowledge so that you could empower yourself for better patient care. Last but not the least, we also take the opportunity to thank our technology partners who have helped us in the very smooth streaming of this webinar. Thank you, one and all. It was great having all of you, and it was an honor hosting you.
Bye.
Thank you.
Thank you, Tani, JC, Brian. Thanks a lot. Bye-bye.
Thank you, everyone.